Is your practice tired of wrestling with insurance denials, deciphering EOBs, and watching your revenue slip through the cracks? You are not alone. Welcome to The Claim Game, the podcast designed to cut through the confusion and provide you with the best practices for revenue cycle management success. We are Jeremy and Catherine Zug, and we've been with people just like you in the trenches. Each week, we'll break down complex billing processes, share real-world solutions from practices like yours, and ask questions of the game makers and changers of healthcare so you can take control of your revenue. Let's turn those claim denials into deposits and help you return to focusing on patient care. It's time to win the claim game.
Hemant, thanks for being on The Claim Game. Can you give us a little intro bio about yourself and how you arrived at, well, we'll talk about your credentials because I don't think I've ever seen credentials like that, but give us a little background on who you are.
Thank you, Jeremy. Hemant Gupta. I'm a hospital medicine physician. I still practice. I grew up in Massachusetts. I'm board certified in internal medicine. Prior career as a CMIO, Chief Medical Informatics Officer in the Northeast in New England with a couple systems here. One was for Ascension Health and the other one was for Holyoke Medical Center. And then I moved to Miami and became a short-term VP CMIO there. Learned a lot about physicians using computers and using them effectively to document things into order. And then from there, I moved on to becoming a sound advisory services, so a physician advisor for sound, working at Tenet Healthcare in Phoenix, and then transitioned to the national team as the national physician advisor, senior medical director for all national for sound advisory services. Of course, I had my CMO that worked very closely in the quality department. We were responsible for 120 physician advisors across the country, hundreds of hospitals, on-site work as well as remote. And then from there, I had an amazing project with Kaiser as a part of Sound Advisory, where we worked on quality of UR for Kaiser for the Mid-Atlantic division for about a year and some change. That landed me to a job at UnitedHealthcare most recently as the National Chief Medical Officer for Network Strategy and UR Innovation, of which I've transitioned out of as of April. And I'm here now with you in the transition world. So that's how I come to be. Yeah.
I mean, that's so many big, reputable organizations. We interviewed Dylan Ross, who came from Kaiser, and it seems like they do some really good work over there and are pretty thoughtful about how they do things. So your role as a physician advisor is at this intersection between like clinical and quality management. How has that changed over the years, and how has that become a really critical role in the modern world with AI and everything?
It's unbelievable, Jeremy. It's transformed into this major sector. I started my physician advisory work in 2007, 2008 in a small hospital in Massachusetts. And, my first question was, what's a physician advisor? It was an unbelievable moment for me to understand. I eventually learned a whole lot more by going to one of the UR conferences with the leadership of a hospital. And then I really learned what it was. Back then I thought, well, we physician advisors, we get called when they have problems with insurance. We have problem with, coverage for a hospital stay. So they call us. I thought, back then, wow, it's just a part-time role. So it's a role where you're a practicing physician, you're part of that medical staff, and the hospital needs better case management. So you lead the case management department with the case managers. And, it's all about a reactive response, like status questions and, oh, we got denied for this. Can you talk to the plan medical director or the hospital, the health insurance? I'll make some phone calls on peer-to-peers. And, it was more reactive. And they were saying, well, can you work with our medical staff to better document things or better status things for inpatient, outpatient? Really, I thought it was a part-time role. I thought it was more reactive. In the last 15 plus years, it has now become proactive. It has become full-time. It has an on-site component and a remote component. And, the ACPA is about 100 members, started in 2014. Today, it's well over several thousand members. And so it is massively increased the interest in practicing physicians and surgeons, inpatient and outpatient, that want to get into the UMUR field, utilization management, utilization review. That's expanded into revenue cycle management, into regulatory compliance, into payer provider contracting. I know physician advisors during the COVID were actually managing throughput and hospital beds because there was such a shortage of beds during COVID. And so the physician advisors became the sort of the quarterback of how do you locate and where do you put patients safely and provide the guidance and treatment. I also know that so many physician advisors also practice inpatient, outpatient, or even surgical, medical surgical specialties, cardiologists, all walks of life. But when they put on that physician advisor hat, they really looked to not just react, but to become proactive. And as part of this expansion, I've also learned there are multiple other societies that train physician advisors. So ACPA has an amazing training program. The American Board of Quality Assurance and Utilization Review Physicians, of which I'm part of the board. I write the exam questions and the core body of knowledge. I'm one of the authors. So I encourage physicians that are in training, that are out in early to mid-career, that want to do this kind of work, to join these organizations, to connect and network, because there's a whole lot of knowledge that is not out there in residency. It is not out there in fellowship. It is definitely not in med school. It's amazing. The field has exploded over the last 15 years, and we have where we are now. It's a burgeoning area of active investment from health systems. And if you become a really good one, you can go to the planned medical director side too, and do the same kind of UMUR work on their side. So it's really wonderful to see the growth of this field.
Just an observation, the more physicians and providers I talk to, the more I'm learning that the expansion of post formal education into these other education bodies is becoming far more important. So I don't know if the education industry needs to expand or if the post education industry needs to expand, but that's what we're noticing. And I think that's what you
Yes.
articulated
So
is
there are
you're
some
getting
places where they have medical schools that are getting into this. What is this? There are certain residency programs that have some rotations in this. Again, this is not 15 years of it. This is this is the tip of the iceberg, a few years in. I don't know of an official university program for this, but I do know you got to know your clinical first. You got to know the practice first. And so if you don't know the clinical and practice, I've seen people not do well because the clinical and practice experience are core to being a great physician advisor. And so, it's really after you've practiced, after you feel comfortable, where all the training, learning, certification exams come in. And I've seen people fly. I've trained 1,000+ folks, but the point is, I've seen people fly because it starts to click on the dot of what needs to be in the record and how do you perform as an advisor. What are those metrics? How do you lead your UMUR committee in your hospital? So there's excellence of content out there now. And I said ACPA, AbCorp, there's even Applecom, which is another third place. The ACMA is beautiful. They're in great organizations that have teams of our folks. It's become a whole industry. And again, happy to help anyone that wants to get into it.
amazing. Well, and we'll put the links down to those organizations below
Sure.
so that if anybody's interested
Absolutely.
to learn or read more, that makes a lot of sense. And so
Mhm.
when we first talked, I was surprised to learn you were still practicing. But I think what you just said there makes a lot of sense.
Yes.
Yeah, and I think you articulated something earlier in how what you're talking about is that one of the biggest sources of friction
Hmm.
in healthcare is this delta between a physician's recommendation and the
Yes.
insurance company or like the third party payer. So,
Yes.
from the depth of experience you've had, and you've had quite a bit, how do we align those two worlds so the patient doesn't get caught in the middle or that patient care falls through the cracks?
Excellent, excellent question. This is in the life cycle, the journey of a physician who's practicing seeing patients, performing procedures, diagnosing, managing treatment, that then gets into this UMUR physician advisory world. They start asking, what's the difference? Why am I doing? What are we actually doing in the UMUR rev cycle world? And so one of the core questions in the evolution of the mind of a physician who's practicing, but then starts to do physician advising. The core question at hand is, the practicing physician is thinking about, what does the patient need? How do I diagnose and treat? The sort of the core function. How do I diagnose this? What are the things that I need to diagnose? And once I have a diagnosis or a differential, how do I treat it? And that's your practicing physician. But now if you put on the physician advisor hat, the questions you ask are a little bit different. And the best physician advisors have bridged that gap. And they have brought that knowledge to their hospital health system, their medical group. And so the question of physician advisor, does the submitted record prove the need or the medical necessity for what is happening? Whether it's the need for a resource, a drug, a procedure, a hospitalization, what's the right setting to treat this condition? And how do I measure impact and effectiveness of that with the limited resources that we do have? So how do I help my health system get through this smoothly? How do I help our member patients get through this smoothly? And so when a doctor writes, hey, this patient has pneumonia, let's admit them to the hospital. The physician advisor thinks, why should this patient be admitted to the hospital? What are the risks if this patient didn't get admitted to the hospital? What are the missing pieces of information that justify this resource use? And so the practicing physician would always ask, why are you questioning me? I'm a doctor. And that's why we have criteria out there. So you could be like, well, these are criteria, these are commercial, they're designed to not work. In sincerity, when I look through these criteria, I see some of the most common board exam type questions that are asked anyway. So you look at the pneumonia guideline for MCG, Interpol, you look at some of the policies and you research on, say, why is the oxygenation level important in a heart failure in a pneumonia patient? Why is that important? And so the medical training behind it does show severity criteria. How severely sick is someone? How intense is their service? And if you didn't provide that care, what are the risks of mortality, morbidity? What are the risks of compromise to that patient? So the medical record really does not, to a physician practicing, mean much. For a UNUR physician advisor who is defending that record and the care that's happening, that defense, the justification, whatever you want to call it, the pieces of information of why are you doing this? What are the risks? How can you justify this care? What's different today? Why today? And so that's important, like real-time, transparent information that is absolutely part of the evaluation of this patient in the record. If you don't assess the patient that well or document that well, then you leave things behind. You really leave the severity, intensity, and all those things behind. You're like, well, I didn't get trained to document that way. I'm like, well, yeah, that's why you have a physician advisor. That's why it's distinguished itself into training people to really document those questions. And that's the difference. That's the rub. That's well, my note is not good enough. Well, it is. We just need to answer some key questions. And
I mean, and within that is sort of a pregnant question about there's like some conflict baked in there, I suppose, right? And I love what you said about, well, isn't my note good enough? I'm also a physician.
yeah,
But I don't think it's all equal. And I don't really understand how you get that real time data with all the disparate systems that exist,
true.
which I know is something that we can certainly talk about. But I don't know how you align those two things in a way that everybody's thrilled with.
Yeah, no, it is true. You have your medical record, you have your revenue cycle system, you have the claims management system of the insurance, you have the clearinghouse, you have multiple segregated systems, but there are layers. And thank you to the interconnectivity with the different standards of CC HIT and ONC regulations that these things are. You can actually these days connect with APIs. But getting a smart layer on top, I think it's amazing that the field is evolving and learning, using NLP, using machine learning, using AI to ease that burden. But the risks here are of note bloat. When EMRs came around, there's a lot of note bloat, a lot of copy paste, a lot of erroneous stuff in there. So it's important that we use these tools and not increase non-helpful ways of bloating the EMR. So focusing in on a clinically led, justifiable pieces of data that is needed, like why is this level of care necessary? What is the objective and severity seen? Why did the prior treatments fail? What are the risks of adverse outcomes? These are the things that I think a physician practicing would not know or see or want to document because it's just a lot of burden, right? And so, why should this trans patient stay in the hospital today? Why? What's different? What's not safe about this patient? I think many times we document in records with templates, and our templates are copy pasted, and everything is hunky dory in the physical exam and the review systems, and everything's perfect. Then tell me, why are they still there? What's keeping them there? And so, Medicare wants this, not just insurance, fee for service. When you get retro audits, they ask, why are they still there? What's the difference? Why'd you make that patient inpatient from observation? What was so bad about it? And so that kind of core typing reasoning, I think AI, NLP, I think the systems can be trained to guide and to make it with integrity, to not bloat it, to not make it falsification, but to actually assist and ping the practicing physicians that are not experts in this to say, that is true. Their history did show that. I didn't write that. And so there's the sort of the lost piece of the puzzle that didn't make it over. And so I think we're in a great age of assisting, not at the risk of putting too much in there that's not relevant.
Yeah, I mean, I'm very bullish on our current age, and it's great answer for sure. And I think what you talked there about audits, and I mean, we talk to clinicians all the time, and there are some definite fear around reviews and audits and clawbacks. What, from your perspective and your experience, what are the common misconceptions that doctors and physicians have about why insurance claims are denied? So that's part one. And then part two, what should physicians and clinicians be doing differently in their documentation?
I love that question. It's such a great question. I think the biggest misconception that physicians that have not worked in the payer space, insurance and audit companies and IREs and IROs and QIOs, the physicians that work there that are reviewing the evidence to speak for or against something, is that everything just is a one kind of denial, right? So there's like only one kind of denial, but in sincerity, it is not one kind of denial. There are different kinds of denials. You could have an administrative denial because a patient is not insured by that specific product. The patient does not have that benefit. It could be claim was erroneously entered multiple units of something, in which case there's some error, it's not found that was actually done. So the clinical doesn't back the claim. So, there are lots of different kinds of denial types. So medical necessity is one. Another one is like there was no information presented to the insurance in a timely manner. So the insurance denied it for lack of information. And you're like,
Yeah.
well, how is that possible? We have EMRs, we have clearinghouses, we have APIs, we have all these interconnects, we have ADT feeds. How's that possible? It's possible. It actually happens. There are delays to documentation, and there are regulatory timelines that have to be met by federal standards. So by that time, if the documentation is not there by the doctor that assimilates all the pieces of the record, and many times these things are just a functional flow issue. So, the world of denial is actually broken down to many kinds of denial. So I'd say pre-service, medical necessity, level of care, continued stay review, coding, site of care, benefit exclusion. And they just grab back of the post-payment audits. So even government agencies for fee-for-service do post-payment audits. Short
All
stay
the time.
review, right? So it is part of, like, a denial is just not a denial. You must, and that's your physician advisor. That's your case manager. That's your rev cycle leaders of your health systems that can efficiently triage the ones that are quickly fixable using technology, using expertise to be able to say, here are the ones we can really get into. Here are the ones it's way beyond the time period to even appeal. And so, there's some things that are entirely not possible, and there's some things that are like low-hanging fruit that you can absolutely push back on and get the overturn. It is absolutely a burden. I accept it. It is an absolute admin fat burden. It's the game that we've set up today. And that's the rub. That's the rub. I'm burned out now. You're burning me out. Well, that's why this industry is developed, because it's there to assist the health systems and the providers. Of course, connect the dots for the payers.
Yeah, I mean, we have to work together as a corpus, right? And I say this to people all the time, but if I discovered a planet that needed healthcare and I threw you on it, I don't know if you would create the system we have, right? I think you would do things a lot better, but swinging the system is really tricky. And I think provider burnout is particularly relevant today.
Absolutely
And
relevant. Absolutely relevant.
Yeah, and we could certainly. It's a whole other podcast to talk about incentives and that kind of thing. But I do think talking about like value based care and talking about
Mhm,
incentive alignment, value based care has been around for a long time. This idea
mhm,
has been thrown out quite a bit. Um,
mhm.
we'll get right back to the podcast episode, but first, let me ask you a question. Who is the highest paid insurance biller in your practice? If you're the one doing your billing, the answer is you. If you're the practice owner and you're a clinician, you know the drill. You do the hard work, you deliver great services. And then there's this waiting game. There's billing after hours and on weekends and during birthday parties, or you go to the office for a quote unquote quick visit, and then you look up at your clock and all of a sudden you've been there for 3 or 4 hours doing billing. Following up on claims is tedious and it creates a massive bottleneck for your cash flow. And that's exactly why Practice Solutions does billing for practices that take insurance. We take your practice's billing completely off your plate. Our team handles everything from eligibility and benefits to charging cards to posting payments, following up on denials. And we deal with insurance companies every single day so that you can focus on growing the practice. It's time to stop stressing over the billing and getting back to what you do best, which is running your business as best as you can. Head over to practicesol.com today to schedule your free consultation to see if our done for you billing services are right for you. All right, let's get back to today's episode. Based on your experience, what are the biggest structural hurdles keeping us from a value based care system rather than just fee for service?
Yeah. So what I can say is this has been there in so many formats over the decade that, pay for performance, the ACO modeling, the bundled payment, this has been with us where we would like to control the costs, but then, do the care for the value and not the volume. It's been there for a long time, yet it is in a constant state of flux. And what I see is there's a lot of different systems that are not fully aligned. So the next, is that to work on really value-based care. A lot of the things that are there, should I say primary care is quite essential. It is a big area of a need. So as in we need more and more and more of it, yet it doesn't get recognized for the impact that it creates.
Mm.
So you have specialty care, value-based care, right? And then you have primary care, value-based care. So the structures must be aligned. So the payer-provider partnership needs to be aligned. And then a data set. What is the data? What's the source of truth? Is it the provider's data? Is it the claims clearinghouse data? Is it the Medicare data? So which sets of data are we aligning on and centering on? So I think truly value-based care works. Initially the thinking was, well, I'm paying for value, not volume. But it's really come down to, are we all rowing in the right direction? Do we have enough supply of primary care? Do we have enough supply? Because many of the things that are costly come from a poor supply of outpatient care. ED
Mm.
gets overutilized, readmissions happen all the time. The specialty care is extremely expensive, right? And that's also a very sort of highly prior authorized, correct? Because they're not all rowing in the same direction and saying, pay me for the procedure I provide. No, let's make sure you get paid for the outcomes or the quality or the impact on health that we provide, as opposed to
Yeah.
I provided a procedure, pay me for it. So we have a lot of hidden fee for service inside the system that
For
has
sure.
not evolved. And that's why I think the value based care question continues to ask us, how do we align our systems? How do we align our data? How do we get more outpatient care happening that's aligned? Where if you just center in on the cost piece of it, it starts to game itself. If you go around saying, I'm interested focusing on health, prevention, I'm focusing in on timely intervention, the right treatment, the right time for the right patient in the right setting. That's part of the sort of the UMUR lore. Let's work towards that. The cost will fix itself. We have to talk about cost, but if you're not aligned there, the cost just suffers. So
Yeah.
to me, the value-based question really becomes it's a hurdle, it's structural, and each system within the ecosystem is sort of honed in on its bottom line, and they're not really honed in on the system. So population health, value-based care. These things are continuing to be fluxed. And of course, the leverage is connections across the system, leverages of predictive analytics, the leverages of risk-based contracts, using AI and NLP, using the ability to say, hey, you can take care of this patient. Let's go work on the riskiest population first. Before those complications happen to the healthy population, let's intervene first. And so the value of that is ultimately shown in lesser resource utilized. And it's sort of a more controlled resource utilized, justified resource utilized, right? And so there are lots of articles about this, lots of articles. And that's where I am. I mean, I'm glad to be in this space, to have worked on both sides, along with a lot of people across the country, to be able to build this better so that we don't keep going fee for service again and again and again and again. That's the sort of thinking, pay me for the care that I do, that's hindering the true value-based care.
Yeah. And when you think about the value-based care, value-informed care brings to the table, it's significant, but it's aligning the incentives and the resources, right? I'll give you a good example. In mental health care,
Yeah.
couples counseling is reimbursed at a lower rate than individual counseling.
Just
right?
an example.
Yeah. Just one example. But if we
Yeah.
were to get families right, then that would ripple out, right? But we don't incentivize family or marriage counseling as highly as we do individual. And so that's exactly what you're talking about. So if we were to align the incentives with what we wanted to see down the line. And I
Yes.
like what you said there, the grid of right patient in the right time
Yeah.
with the right intervention in the right setting. That's a great grid.
So some of the big ACOs that formed in 2024, so the Medicare Shared Savings Program in 2024 had low revenue ACOs and they had sort of the high revenue ACOs. And guess what they found? Something that we already knew. The low revenue ACOs that focused on better primary care, more integrated primary care, had the greatest net per capita savings. Why?
Imagine that.
Because it's health. We're looking for health. We're not looking for when it all went down the drain and now we have all this expensive care. So, systems that are hinged in, I hate to say it, but systems that are hinged by hospitals, they survive off of filled beds that they can generate revenue off of and survive, which is needed, versus systems that are outpatient based or community center based. They want to keep that patient healthy. So the incentives are a little different. So like, who are you asking to initiate these care arrangements, these models of care? So I really think it's like operating model. It's not a payment model, it's an operating model.
Yeah, that's good.
Operating model is if the people in the outside the hospital are truly centered or aligned, or we can actually take prevention, we can take mental health, we can take all the stuff that's out there and provide that better in a value-oriented way, then yes, you still need hospitals. It's the backbone of America, right? But that's not their incentive, is to survive the acute care. So a lot of our stuff is focused on acute care with cost control as opposed to non-acute care and integrated. So non-acute care integrated. So that's what the ACO showed. The ones that saved the most amount of money were focused on outside the hospital care.
Makes sense. Makes a ton of sense. Yeah, and if that were to be achieved, right? If value-based care, let's say we ask chat and chat comes up with the best version of this, one of the unintended consequences would be a higher level of trust in the managed care industry or health insurance companies. And I feel like we're sort of at a bottom of trust in the third-party payment model.
Yes.
And I think what you just talked about is like, it's an operational model, not a financial model. What would a transparent insurance model look like? And is that even doable? Or are we like so far down the road that rolling that back is going to be impossible?
I think the core problem between payers and providers, whether it's employers that have third-party administration, level funded, fully insured, administrative services only, whatever the pitch you want to make, the biggest problem is of trust. So trust and transparency. So a lot out there. So 2026 Kaiser family poll, Kaiser study showed 69% of insured adults had a prior authorization. 34% of the, roughly half, the study, the sort of the polling showed that the prior auth is sort of the biggest rub for third party payer, right? The prior auth, why is it there? It is gaining government attention, it's gaining IT company attention, it's gaining state government attention of how it gets in the way of care. It slows the access down and people suffer from it. And so that generates a sense of a trust problem. So AHIP, the large insurance companies, they're trying to build out the gold card program to say, hey, we're going to remove some of this prior auth.
Yeah, wiser.
They're trying to build trust by saying, we will make the process of prior auth, if we have to do it, exceedingly simple, easy using technology, near real time. So the trust erosion is an issue, and it comes from some of the current business practices of the system. So when you sign up for insurance, do you know what you're being covered for? So I would recommend our system move towards coverage transparency. Patients should know exactly what they're being covered for. They should know what requires a prior auth. They should know when they get denied why. What were the criteria? What was the decisioning? And they absolutely need to know the denial patterns. That should be transparent. This process is, so take a form of treatment that I think everyone wants these days is GLP-1s, correct?
Yeah.
The last 3 years, 4 years. Everyone wants one. Yet the clinical criteria that have evolved over the years, I said, no, it's for obese people and some who are diabetic.
Yeah, it's been around for a long time.
Well, everyone wants it. It's been known for a while, but when it gets through the ringer of policy, process, proof, order, approve, those questions get asked. And then people are like, why am I not eligible for it? It's because the perception of what it's eligible for is not brought to the center stage by payers, providers. And so the providers, where's their responsibility to say, I learned medicine. I learned it by studying in med school. I also learned it in the journal articles and research paper. Where's that lead that says, no, actually, Mrs. Smith, this isn't for you currently. It won't be covered and the evidence doesn't show it. And they're like, well, no, you're wrong. You go to another doctor. The consumerism is there. We absolutely need to be price transparent. As I said, we need to be price transparent, coverage transparent, and really where it's needed, we need to stop it. So if someone is obese and diabetic, I don't even want to have a prior auth. Just do it. Go do it. I trust you. Order it. Done. We don't need any, right? So where it's low hanging fruit, you're practicing in the right pattern, there's no prior auth. So, and then what does it cost? Like, we don't know what a hospitalization costs. We don't know what a colonoscopy may be costing. We don't know what a knee procedure may be costing. But there are regulations now, and there are applications and companies that are doing this. The payers are doing it. Some of the forefront hospitals are doing it. This concept of price transparency is important.
It's super critical.
Cost Plus Drugs is doing it. So the beauty is price transparency is important, is very important.
It's super important. Yeah, and it won't put certain providers out of business, right? I mean, if you charge more, some people will pay more.
Right.
Right? And then some people will want to price shop. So it's not going to
kill you. We're capitalistic. You'll go shop around for the best price for the right thing. I think that's actually happening. UnitedHealthcare has done that. Surest Health Plan has done that. There's good stuff. It's happening. It's growing. It's not out in the mainstream, but it's there. And it's continuing to evolve. The field is evolving to say, make it transparent, make the denial transparent, make the cost transparent, make the care transparent. You can't approve everything forever all at once. It just doesn't exist. So we saw the shortages in COVID. We learned about that. You can't have everyone do everything all at once forever. It just doesn't exist. It's not possible. So then where do you make the right decisions? You make the right decisions with the doctor and the patient, that they're practicing within this evidence-based, outcomes-based, health-based process. But then within that, we want transparency. Here's why. Here's how much it costs. Get it to me if it's ready. Don't delay me. Do not delay me. Meaning, if I'm within the guardrails and I meet it, simple, hit it, get the care, because we don't have time for delay. We don't want that. So I think the true value that comes from trust, employer transparency, PBM transparency, like the cost transparency, These are the things that help the system gain. They're rowing together because health outcomes and the total cost of care is a shared incentive for everyone. And so again, you have ecosystems that are doing that. Then there are some ecosystems that are entirely way behind. They're still stuck in 1960 fee for service. Still, they're they're like, well, let me write a huge note so I can maximize my reimbursement. You gotta maximize. That's why I say a lot of people have their own math, own equations, and the equations are not aligned. So they survive because they have their own equations. So if I
Yeah.
maximize, if everyone's gaming the system,
It's not
that's
going to work. It's not going
it's
to
not
work.
going to work. Right. So in this situation, the system loses. And so
Right.
we have the collective responsibility as care providers, as insurers, as payers, as employers to really align in that direction. These are exciting times.
Yeah, they are exciting times. And so you talked about AI too, and I'm curious if you see AI from both the managed care perspective and the provider perspective, lessening the friction between the two, or do you feel like managed care is going to use AI as like a denial machine? And I
Yeah,
think it's the
that's a
public
great
perception.
question. Such
I
a
know
good
it's
question.
maybe a tender question, but what do you think?
An excellent question. So if AI is a tool, I have great responsibility, great power to use that tool. Again, am I using it for responsible use or I'm using it for to perverse and game the system? So you will absolutely see the tool. The tool can be honed into doing all kinds of things that are one-sided in the equation, let's just say. So I do see AI being used by the electronic medical record, Epic, Cerner, they all have it. Ambient AI to create your note. The AI can have errors. It absolutely has hallucinations. And if you're
All the
not
time.
responsible for that, you will create a bloated note that may not be true. Their AI is inside the insurance side too. They're looking at parsing all kinds of clinical data to find out what are the things that it does not have to rapidly bring that information in front of a medical director and say, hey, deny. So the regulatory environment on that is still evolving because currently the regulation says you can't auto deny using AI. And I have not seen that in my career. So I've worked at UnitedHealthcare. I've worked at many health systems. I've been a physician advisor. I've not seen AI auto deny, though it's a fear that it could potentially happen. I have seen companies, Cohere, Humana, seen a bunch of companies in the prior auth space, Stanson Health, a bunch of good companies. But let's take even Change Healthcare, that they have the interqual auto review solution and various different prior auth, real-time prior auth, Optum Real, all of these solutions, they're really trying to say, well, we're within the guardrails. Let's use AI to approve things quickly within the guardrails. We're already within the guardrails. It's like Jerry Maguire, you already approved, you're good. We don't need to take more steps. You're
Yeah.
good. You already meet all the, you're in the guidelines, right? You have diabetes, here are your meds, here's being managed, and it justifies the use of metformin. We don't
Right.
need, so there are a lot of things that just need to come off that list, but
Mhm.
AI can rapidly sift things that are not questionable and literally just make care great again. Let's just say easy again,
Yeah.
quick again, payable again, whatever you want to call it. Because
Yeah.
it's not worth squeezing the juice there. It's not worth it. It's just not.
Yeah. The squeeze
It's
is
not
not worth the
helpful.
juice.
It's not helpful. So can AI help us sift through all of the easy stuff and fast approve things that just doesn't make sense to deny, right? So
Yeah.
that it can do. I think the documentation it can help on. I think claim coding and again, I have to say, not everyone is in the shoe of the magnanimous. Let's improve the system. Some people are like, let's over document. Let's keep documenting these things because their reimbursement is high. That happens every day. So AI can catch that because fraud, waste, and abuse is not going away. So the
No.
point is, AI can learn to catch fraud, waste, abuse on both sides, insurance, employer, all parties. Okay, so I want to preface this. When I say fraud, waste, abuse, I don't mean providers. I mean the system. So we should be able to surveil the system and find things that are off the guardrails and really catch them early before they happen. And they really suck money out of this resource, right? Ordered all this equipment, it's not really needed. We paid for it, the equipment is gone, and now we're trying to find out what happened. To me, the most important thing is to be proactive concurrent.
Mm.
proactive concurrent, not do the care, provide the care, pay for the care, and then ask questions later. That's old fee for service. Not interested in that. I think if we can leverage that and make it smooth, quick, fast, and current, you can actually save resource. You can direct patients to the care they absolutely need. But in the end, that's the beauty and the promise of AI. How can we use it impactfully for the system? And that's a great question.
Are you bullish on healthcare becoming affordable with technology, or are you the opposite? Do you think healthcare will continue to get more expensive?
I think if you can, the technology itself is not free. It costs money. So when EMRs came around like 50, 20 years, a while back, there's a huge uplift for all the installations, the licensing fees, the security, HIPAA. The ONC HIT recently did a great, CC HIT did an interview talking about smart prior auths and smart documentation, smart connectivity with in outpatient offices. There is going to be a cost to that. I think that we absolutely need to invest into that. But I think the overall cost should decrease, because if I can focus my intention on where care is absolutely needed, and I can, resource align to where care is absolutely needed, and not designed around a gigantic hammer that is not specialized. It's very expensive to do everything all at once. So there has to be a balance between the IT costs and the costs of generation versus the unit cost reduction. Like, I can do things much faster now. Instead of having 30 steps that is manual, we can have 2 steps or 5 steps that are automated. It's a whole lot faster. So while you get efficiency, cost saving, you also have to intelligently design it where the cost of doing the technology itself doesn't supersede the current
The
system.
benefit. Yeah, right. Because then it just like rolls up to everybody.
That there's a lot that the future can hold, but it's going to require a lot of collaborative thinking. And so the tech companies, the employers, the hospitals, the independent providers, the pharmacy, the specialty care, the post-acute care space have to align, and they have to leverage the technology of where it makes sense to have lots of human force versus things that just don't need human force. They're just create this industry of manual everything. It absolutely can slow things down and become costly, actually unsafe for patients. So there may be a safety thing, a cost thing, a transparency thing, an efficiency thing that comes from using leveraging technology. And there are tons of companies from Silicon Valley, ChatGPT, there are tons that are out there that are producing to these models. The goal is better care, cheaper care, quality care.
Yeah.
And
I mean, it's expensive now for sure, and it's time to do something. If people want more of what you have to bring to the table in their lives, how do they find you? Where do they go to watch or follow along? Or do you write updates on your thoughts on healthcare, like what's coming next, or do
I
people
do.
get more Hemant in their lives?
They absolutely can get more of me. They can reach out to me. Again, I have my LinkedIn post, of course, LinkedIn profile that you can put there. They can read. I'm happy to connect with folks online. Absolutely. I'm looking to develop a podcast series, or maybe the blog series. But yes, I look forward to engaging in as many ways as possible with industry leaders and practitioners and, folks from all walks, and to be able to collaborate with them. And yourself too. If you want to do more, happy to connect.
Amazing. Well, I have more questions, but I feel like we're out of time. But we'll definitely have you on again for sure. But thank you, Hemant, for being here and for sharing so much insight into how this stuff is working.
Thank you, Jeremy. It's been a pleasure. Thank you.
Amazing.
Take care.
If you enjoyed today's episode of The Claim Game, please take a moment to leave us a rating and review wherever you listen to your podcasts. It really helps new listeners to find us. Make sure you never miss an episode by subscribing to The Claim Game on your favorite podcast app. Your feedback means so much to us. We want to provide valuable education about revenue cycle management. So if there's something we didn't cover in our topic that was a burning question for you, please let us know so we can try to get you the information you desire. You can find the links to all resources we mentioned in this episode in the show notes. And if you want to dive deeper into our resources, we have 2 places you can do that. First, you can go to our blog at practicesol.com practicesol.com/blog, where we have 8 years of educational blogs. If you want to learn more about what Practice Solutions does, reach out. We'd love to hear from you. Just go to practicesol.com to learn more and to connect with one of our awesome people on our team. Thanks for listening. We are Jeremy and Catherine Zug, and this is The Claim Game. See you at the game table next time.